morning, everybody. It's a pleasure for me to be here once again among so many Apollo Hospital colleagues, friends, the leadership. You always have been an inspiration to me personally and to JCI about your dedication to the patients that you see on a daily basis and to others that you're influencing the quality of care around India. This is a particularly interesting time for me to be the first speaker because at the Calcutta meeting last year, I was the last speaker on the last day. So to be the first speaker on the first day is truly wonderful. The other reason is I was presented with a topic title, The Patient Safety Goals in the Year 2020. And at first I thought I had nothing to say about that. And then I thought, well, you know, we're in the process of revising the hospital standards for JCI for the 6th edition. In about 4 weeks, we're going to meet with the Standards Advisory Panel and begin to talk about what we need to do to keep the standards fresh, to keep the standards pointing you in the right direction for a very different future. And one of those topics will be, what do we do with the patient safety goals? So I'm going to push it a little further to look out to the year 2020, and much of this is supposition at this point, but we won't know if I'm right until the year 2020, so it's a pretty safe topic for me to talk about. If somebody can show me how to change the slides. And we need the slides up on the monitor as well. Okay. You know, I don't see it here. Okay. Shall we go ahead? I can. We'll go ahead. Okay. Okay. How I'd like to lead you into this topic this morning is first to step back a bit and talk about the origin of patient safety goals, looking at what the Institute of Medicine has done and WHO has done. Then I'd like to take a look with you at the Joint Commission International patient safety goals, their origin and what they mean, and then ask the question, what do we need to do from here on? Do we need to modify them, jettison them, and start all over again, tweak them? What are we going to do, and why should we do that? And then looking at what is the alternative. So many of the presentations over the next couple days will start with a slide similar to this because it goes back to the 1999 report of the Institute of Medicine, To Err is Human, and then the subsequent publications, including Crossing the Quality Chasm and others that deal with quality and patient safety around the world. This was the wake-up call, the realization that a lot of people were dying in hospitals from preventable errors. So it caught the attention of the world, and that's really the origin of the patient safety movement around the world. The Institute of Medicine in the second report, Crossing the Quality Chasm, looked at what should be the activity strands for this effort around the world. And they're here. The first was the global patient safety. The first was patient safety, of course. And that was the primary strand coming out of the Institute of Medicine report. But they also looked at other aspects of care. One was the effectiveness. Much of the care that is provided is not effective, but also looking at patient-centered care, and that has become an important movement, and there's a lot of conferences around the world now on patient-centered care. The other is timeliness. Frequently, the delay of treatment or the delay in diagnosis creates a patient safety problem. Efficiency certainly is important because the health resources in most countries are stretched pretty far, and we need to be more efficient. And then the equity, the distribution of care creates unsafe environments and situations and poor care in many parts of the world. So this was coming out of the Institute of Medicine report and what we should do. What I find interesting on this is if you listen to IHI and what they're talking about now is better patient care, more efficient patient care, and population health. And this begins to come out of a report like this. The next thing that I'd like to point out was the creation of the World Alliance for Patient Safety. This was announced in Washington in 2004 to great fanfare. And this World Alliance also had a number of activity strands through it. The first was the Global Patient Safety Challenges. So they decided that it would be good for us to focus around the world on one challenge at a time. And so they put forward some challenges to us. The second is bringing out the patients for patient safety, putting the face on the issue, and hearing families of patients who had died from mistakes and from errors, to begin to understand the human toll and the emotional toll on families as well as on the care providers. And then the taxonomy. There was a lot of different terms used in the patient safety movement, and so WHO said we need to get a handle on this and we should understand what we're all talking about. And then the reporting systems and research, and then the dissemination of solutions. Now, JCI was very fortunate to have a role. It was the only collaborating center for patient safety solutions. JCI also took leadership role in what was called the High Fives program, which was to introduce standard operating procedures related to patient safety in 5 different countries. It expanded to about 7. That program has now been completed. We also, through the research division, did the taxonomy, and we have contributed to many of the different strands of WHO. The 2 challenges, I did a lot of looking at the WHO website, trying to find out what the series of challenges, the total series, but only 2 have come out. The first one is clean care is safe care. Now, this is a very complex one. It's just not cleaning your hands before seeing a patient. This goes to societies and countries where they don't have adequate water or adequate clean water. So this is a pretty comprehensive challenge, world challenge from WHO. The second one was safe surgery. And this will trigger the thoughts regarding the patient assisting in marking surgical sites, the surgical checklist, the timeout procedure, and a number of those things that have been shown to create safer circumstances for surgery. So these were the first WHO challenges. Now, how did that lead into JCI, patient safety goals? Well, we took a look at what the Institute of Medicine was discussing. We took a look, and we're part of the World Health Alliance for Patient Safety from WHO, and we put together what we thought was a short but reasonable list of, could I have a water? Put together a short but reasonable list of what we thought we should put in the standards and have accreditation organizations focus on. The first one was identify patients correctly. And this is the one that we had two identifiers for every patient before you were doing a particular procedure or before you were going to draw blood or give blood. The second one was to improve effective communication. And this was when you take something over the phone, you write it down and you read it back. The third one was improve the safety of high alert medications, basically take them off the unit so that you don't accidentally give a concentrated electrolyte instead of a dilute electrolyte. The next one was ensure correct site, correct procedure, correct surgery, and that drew off from the WHO safe surgery one. Then reduce the risk of healthcare-associated infections, and that one, we ask organizations to adopt hand hygiene guidelines from a recognized authority. And then the sixth one, reduce the risk of patient harm from falls. Now, I should note here, all of these refer to or focus on negative incidents. So you fell, you operated on the wrong body parts, you failed to clean your hands, you got the drug wrong that when you took the order over the telephone. All of these are on adverse events and situations rather than on positive aspects. So, in looking, we said, well, what should we do? Should we continue the goals as they are? It's a possibility. They've been there for quite a while now, since 2008. So, shall we continue them? Shall we modify them? So let me show you some of the evidence that to me speaks that we need to do something very different for the future in thinking about 2020. First of all, we are at 10 years now following that initial to err as human report. So going back, Professor Wachter has written two articles that are published in Health Affairs. One, he did a summary of the 5 years of experience, and then he did another one at 10 years of experience. He looked at a host of factors, and we've just condensed it down to these particular ones, but he gave them a grade. And it's interesting to note here that in 2004, there was some positive activity. He found that healthcare and patient safety regulations around the United States in particular had been changing to be more positive and supportive of patient safety. That slipped in 2009. And you can see the other ones here that when it started out fairly encouraging, excuse me, we haven't made a lot of progress. So that's one factor. We need to wonder, why aren't we making more progress around the world after 10 years of trying patient safety and the various strategies that the Institute of Medicine put forward? The second piece of evidence I'd like to share with you is there seems to me to be a very subtle shift going on at WHO in terms of de-emphasizing these negative aspects of patient safety and moving positive aspects into the patient care process. So rather than highlight that a patient fell and gathering data on that, you begin to look at systems and begin to look at patient assessment systems. So this is one of their publications, the Service Delivery and Safety. It's a major reorganization at WHO. If you look at this booklet, they have drawn in all kinds of patient safety activities into this new delivery unit. And in there is the surgical checklist and some of the other things that we have come to know from WHO work. So that's the second thing I'd like to draw your attention to. Not only haven't we made much progress since the Institute of Medicine activities, but there's a subtle shift in how WHO is thinking, excuse me, is thinking about patient safety. There is another aspect that I'd like to draw your attention to, is that the theory that if you adopt a hand hygiene guideline, it will help increase hand hygiene compliance across an organization. Well, that is a mentality of one size fits all. And what we've looked at through a Center for Transforming Healthcare is a targeted solution tool. This is a tool that a hospital can use, and we have made this accessible to all our JCI hospitals around the world. But you can look at reasons for lack of hand hygiene across an organization. We've tested this in different parts of the world, different cultures, different hospitals, and very interesting results. If you look at what are the most common contributing factors to the lack of hand hygiene, it's a variety of things. The follow entry or exit. It's very clear that if the first person into the patient room does not clean their hands, the rest of the people following them won't do it either. Same thing on exit. So there's a definite issue there. When your hands are full of supplies, you can't clean your hands properly. So these are all the different areas that we looked at. And if you look across the top of this chart, the pilot hospitals are given a letter, A, B, C, D, E, and then underneath them are the number of units in which they tested the hand hygiene issues. And then the X's show you what was the primary issue for the lack of hand hygiene. What you see is no clear pattern. Every organization had different hand hygiene barriers. And even within a particular hospital, different units had different barriers to hand hygiene. So this supports what I said, that we need to think that the strategies for patient safety are not generic across the country, generic in a hospital, but they are very peculiar to each unit and each situation. So this tells me that maybe the singular emphasis on established goals, one size fits all, is not quite correct. Then another very disappointing thing. We have had the International Patient Safety Goals in the manual since 2009, over on the left here. And in the recent 5th edition, which is kind of a little to the right of the center of that chart, we introduced stricter decision rules on those international patient safety goals. You no longer could get a zero, non-compliance in any one of the measurable elements of those goals and pass accreditation. So that was pretty strict. The disappointing fact is, look at the compliance rate has gone down, and it's not back up to where, or just about where it was when we started with the international patient safety goals. We're going to be talking about this because I'm not sure what this means. I'm not sure whether people have become so used to the two identifiers with patients, or so used to fall assessment, or so used to checklists in surgery that they're not paying much attention to it anymore, and the compliance rate is falling off. But this is a significant factor to at least telling me that we need to do something a little bit different. So, what's possible replacements or modifications of the JCI goals? Now, I'm going out on a limb here because I'm not so sure any of my colleagues believe exactly this way, and I'm delighted that we have a board member here in the audience who can hold me to the fire on this, but I'm going to tell you what I think we need to do with those patient safety goals. First of all, we could keep the same set of 6 goals, but wrap them in the concept of systems, which we haven't done. So when you talk about patient safety identification correctly, that's a system of communication. It is one little piece of how you communicate critical information. The read back, write back is one piece of communication within the medication management system, just as reducing patient harm from falls is one piece of the system in your hospital for patient assessment. So a possibility is that we could take these patient safety goals, which are incidents, and wrap them in the systems in which they belong in your hospital, following the WHO leadership of bringing patient safety down into the daily processes and systems in your organization. Another possibility is to just look at systems, not try to wrap the current goals in anything, but just go directly to looking at systems. And so, first system, these are not approved systems. They're the ones that I think are major systems in the hospital. So the first one is looking at medications. So in that, you have medication reconciliation, part of the critical patient safety issue. In medication management, you have antibiotic stewardship and so many other things about medications, the safe supply of medications and a consistent supply of medications. So you take a systems approach and key patient safety issues. The next one, there's a lot of talk about technology with colleagues around this meeting, but I'm concerned that we haven't paid much attention to the security of the information systems and so that we have. There are now reports of, many reports of patient records have been hacked and taken out of major healthcare institutions around the world. I heard the other day about the ability of hackers to go into implantable medical devices, say an insulin infusion pump, and change the dosage and give the patient a fatal dose of insulin, or turn the insulin pump off, or turn a pacemaker off. So there's all kinds of issues that are coming out that mean that we have to pay more close attention to it. Medtronic and a lot of others are also. Thank you. I think if we look at that, that is a system of protecting the technology that we have in our organization. Now, we could look at the patients that drain most of the resources off our healthcare system. In the United States, about 20% of the patients provided service under Medicare and Medicaid have 3 or more chronic diseases. Those patients account for almost 70% of what's spent on healthcare in the United States. 70% goes to patients with 3 or more chronic diseases. But we don't know much about how to treat them. There's a big effort by Health and Human Services to educate physicians and other healthcare providers on what do we do with these patients with multiple chronic diseases. Well, what comes out of all of it is there needs to be a single care plan. There needs to be constant communication of all the care providers. So the cardiologist is talking to the immunologist, is talking to the other physicians that are seeing the patient, and they have to use their resources effectively. This is one of those strands on effectiveness and efficiency. There are problems with it, though, because we're ways away. There are no good evidence-based guidelines on how to care for a patient with multiple chronic diseases. There's no good measurement instruments for outcomes for patients with multiple chronic diseases. And there isn't a lot of experience with single care plans for patients with chronic diseases. However, that will be, in the future, the drain on all of our resources around the world. The next one is integration of care across the continuum. Now, this goes with patients with chronic disease. It goes with patient-centered care. So if you look across the continuum, you can really see a visible potential for impacting the health of the population. It moves it up to that different level. And it, of course, will use community resources more effectively. Finally, there is a system that could be strengthened. If you look in the news media and so, there's a report out recently in the United States that 1 out of 10 individuals, they do not get the diagnosis of that patient correct. 1 out of 10. But yet there isn't a lot known about how you measure that and how you make adjustments for it so that you improve the diagnostic rate of patients and reduce errors. So if we just look in the JCI manual for hospitals, there is a whole chapter on patient assessment. And maybe that needs to be sharpened instead of just concentrating on one fact. So, my conclusion from all of this is we have to wait till 2020 to see if much of this comes to pass, but I firmly believe that at least the care of individuals with multiple chronic conditions is going to be key. My understanding is that the European Commission has directed the member states of the European Union to focus new money on integrated care for chronic disease management because many of the budgets with the elderly, growing elderly population, the healthcare budgets are being stripped bare by these types of patients. So, in the next few months, JCI will be looking at what we are going to be doing with the international patient safety goals. We need your contribution to that effort. We will be doing focus groups around the world. We will be doing SurveyMonkey and surveys on the internet. And please, if you have an opportunity or access to any of those, give us your feedback. Now, the goals have been great in galvanizing people to take action in certain areas, but they're not the long-term solution to patient safety. The long-term solution is getting down into the care processes, looking at them as systems of care, and looking at where we can coordinate, integrate, and more comprehensively treat our patients. And I thank you very much.